Welcome to QD Clinic. I'm Jack Cush with Room Now. QD Clinic is brought to you by Room Now's coverage of ACR 2021. ACR 21 is coming. It's time to get ready. It's time to study, cram. Room Now can be your tutor, your guide, your cliff notes. Be sure to watch us. Watch for our email every day. Watch us on the website. I think you'll like our coverage. Today we're going to talk about scary steroids. I've talked about steroids in the past. They are acutely wonderful, chronically dangerous. You know the case. The patient comes in, has been on steroids for 4 years, doing well, but you can't get them off that dose of steroids. They're still on 6 milligrams. They're still on 2.5 milligrams. They're still on 10 milligrams, God forbid. Or someone's acutely ill or just starting with a new diagnosis. Do you use steroids to start them out? Are you worried about what's going to happen later on? You know, the data on steroid weanings, is not that good. So first, the benefits of steroids are clear. They are wonderful. They do work fast. They do make you, the clinician, look really good. You know, the only patients who have come back at the second visit or come back unscheduled to give me a hug and a kiss, and I mean even older men, were the ones I gave steroids to. The question, of course, is how are you going to get them off the stuff? So the data on benefits are clear. Even low doses have benefits, starting at a higher dose like the COBRA regimen, where patients get combinations of DMARDs along with a high dose of steroids that get weaned down, and then you wean them off. That works really wonderful. The data is almost as good. Even using conventional DMARDs with steroids, you can get data as good as using any biologic. So no one argues about the benefits of steroids. But the question is, you know, do we use them like the guidelines say? Should we use them just as bridge therapy and then discontinue? So there's this catch-22. There's the good and the bad of steroids. Actually, it's a catch-30-30. Data coming from the Canadian early RA cohort study called CATCH looked at a large number of early RA patients, and 30% of them were treated with steroids at the outset of their illness. When they follow them over time, of that 30% on steroids, only 30% of them were able to wean 30% could not wean off of steroids. So as much as we'd like to use as bridge therapy, often we do not. And there are consequences to that. You know, this was also looked at by Gerd Burmester in the Samira study, which we've talked about before. In that study, a large cohort of patients taking tocilizumab and conventional DMARDs and steroids achieved a low disease activity state for more than 6 months, and then they randomized them to either continue their low-dose steroids, I want to say like 5 to 7 milligrams, or to wean them off steroids. And the group that continued steroids, 24 weeks later, 77% of them, three-quarters, were able to be in great shape, meaning they stayed in low disease activity and they had no flares. What about the ones who weaned off of steroids? 65% were able to stay in LDA with no flare. So basically continuing the steroids seemed to be the recommendation, but there was only about a 12% advantage to doing that. And in this short study of 6 months, there was no downside, meaning there was no adverse event differences. But you know, that's not going to hold up in court. That's not going to hold up over the next year, 2 or 5 years, because there's a horrible long-term effect with steroids, and we know that. You know, guidelines say that they should be used as bridge therapy and be done with. In fact, the ACR guidelines are more militant about avoiding steroid use. Interesting data comes from the ICE-BIO study. This is an Icelandic registry of RA patients and SPA patients and psoriatic patients going on biologics. In this large cohort, in the 2 years prior to starting their biologic, there was a doubling of steroid use. And then they started the biologic, and you would assume that they would continue to do great on the expensive biologic, and they would be able to withdraw the toxic steroids. Not so much. 1/3 to 1/2 of patients were able to taper, and it was different between the different diseases. It was easier in SPA and harder in RA. But, you know, the problem here is that maybe 1/3 of the patients also ended up on treatment for glucocorticoid-related osteoporosis risk, or in fact osteoporosis. So we're not that good at getting off. Even though we have the best intentions, we know the answer to the question, well, it's an MCQ question, but we don't. So there's a horrible downside to continued steroids. Peter Merkel a few years ago said at ACR meeting, steroids are the best drug we have and the worst drug, and steroids are the worst drug we have. That's one of the most popular quotes we have in our Room Now coverage. Look for more quotes this year. But glucocorticoid-induced osteoporosis is a common consequence, and now you're treating the adverse event of a drug, osteoporosis from steroids, with another drug that's got its own adverse events. Again, that's a special kind of stupid, is it not? We have recent data that we've talked about on the risk of serious infections, hospitalizable infections, is significantly higher even on doses of 1 to 4 milligrams a day. So there's no such thing as, well, that's a safe dose of steroid. Not really. It's a significantly higher risk of hospitalizable infection. Similarly, a significantly higher risk of cardiac disease, including atrial fib and other events when you use, again, the same doses less than 5 milligrams. So we have this never-ending problem of a circular fight to try to wean patients, but they get worse. Are they getting worse from their disease flaring? Are they getting worse from steroid withdrawal symptoms? More likely the latter than the former. We've talked about that in the past. So what can you do? The guidelines are clear. Use it as bridge therapy. They got it right. And we really should be hell-bent on achieving that goal. You should actively wean and discontinue steroids once you have your bridge effect that's happened. But bottom line is you really need to scare the hell out of the patient. And frankly, the doctor should be just as scared about the chronic consequences of steroids. It's ugly. It shouldn't happen. It does happen. Of course, what I do, I start steroids. I tell the patient, look, I'm going to give you this drug. It's going to make you feel great, but it's going to make you have problems if we stay on a long time. I don't want you to stay on a long time, but if you do stay on a long time, here's some of the things that are going to happen. And there's a handout I'm going to give you that you can show this to the patient. Here's some of the things that are going to happen. You're going to get fat, diabetic, hypertensive. You're going to get cataracts. Your muscles are going to get weak. You're going to get stomach ulcers or stomach upset. You're going to get edema and fluid retention. There's a higher risk of heart disease. There's osteoporosis. Oh, yeah, and then there's fractures. There's bruising. There's thin skin. There's wound healing problems. There's acne problems. You're going to get more common colds and flu. You're going to get more serious hospitalizable infections. There's mood problems, depression problems, mania and psychosis, and you're going to sleep lousy. Maybe you want to be weaned off that medicine as soon as that's possible. So look for that handout. It's the daily download on the Room Now website. It's called Scary Steroids. There's 2 versions of that. Print it out, laminate it, show it to your patients. Again, you can do more good by giving less prednisone. I'll end by reminding you, you can register for something new this year called our Daily Recap. At the end of the day, at the ACR starting Friday, Saturday, Sunday, Monday, and Tuesday, we're going to have a 7 p.m. live webinar. We're going to stream it right to you. Rheumatologists will get an invite to participate in the daily recaps. You can tune in and ask questions, but we're going to discuss the highlights of every day as they happen. That starts with the opening ceremonies on Friday. It's going to end with, and we're going to have a bunch of our faculty that are going to sit around a sort of a round table and discuss that. If you've got any questions, we'll take them. The last day, Tuesday night, is going to be Artie Kavanaugh and I giving Rheumatology Roundup. Sign up rooms. You're going to get that invite in the mail a few times in the next few days. The rest of you who aren't registered rheumatologists can also watch by going to the Room Now YouTube channel, and you can watch the live stream there. Also, we're going to put it on the website if anyone misses it. Tune in for more QD Clinics.